Hello.
Hello, doctor.
Well, how are you guys doing?
Not bad, thank you. How are you doing?
Fine. So actually, I was just concerned about the group which we have made. We are about to separate their tasks, so every one of you are aware of that. So soon we'll be taking an NBME. Those who are about to give their exam in 1 month or 1.5. So for them, just get prepared. You guys will be giving your NBME in this week, and then you'll be separating the tasks. Like almost all of the systems are going to be done within 1 or 1.5 week. Then we'll be transitioning to our um, revision phase. But those who have like booked their exam, so we are arranging an NBME for them, and also we will be then separating their task. So we'll be giving them individual tasks, and we'll be assigning a mentor on them. So that's a thing, right? So how much of you guys have you are they're planning to give their exam soon within a month or 1.5 months? Okay, Judith, Ria, Vipti. Okay, listen. Okay, that's great. So we have already made a group. Have you guys just joined that group? Hello.
Yes, sir.
Okay, perfect. That's perfect. So this week we are going to arrange an NVMe session, and then we'll be separating the tasks. You guys should be prepared for that. And for the research, we are also going to till now we were just recruiting new crew members to our research group, and we were just giving them training. Dr. Abdullah was there. He have recruited a good crew, a good team for you guys. So soon we'll be starting the research as well, right? So we'll just let you know. And for the assessment, those who have given their neuro assessment, although there was some issues with the time, I think Dr. Hamza just gave 40 minutes. Like it was supposed to be 1 hour, but besides that, you guys did very well in your neuro. And you know, so we are only left with like GI and our repro. Right after that, all of you guys know will be transitioning to our revision phase along with the minors, right? Okay, and regarding Dr. Maheen, like she's nowadays she's busy in some documentation for our match, and today I just called her. She was ill, so she'll also join from Monday, and that's all. Okay, so can you guys just see my screen? Let's start our session. Hello.
Not yet.
Okay, one thing which I want to ask. Yesterday, did you guys just discuss your UWorld MCQ on Discord server? Were you there on your Discord?
No, we didn't.
Okay, so from now onwards, please just try to have discussion on your Discord servers, because we have made the servers for you guys. So just take advantage of them. Okay. So okay. So today we are going to discuss the visceral anatomy, and today we'll be discussing structures, which structures are retroperitoneal, and we have a lot of UWorld MCQ on that as well. But before discussing that, let's discuss a little bit anatomy, right? So all of you guys are aware of the term peritoneum, right? So peritoneum is basically covering of your organs, of your internal organs. So basically peritoneal is divided into two structures, okay, or two layers, we can say. Like you have your parietal peritoneum and your visceral peritoneum. Who is going to tell me the difference between parietal peritoneum and visceral peritoneum? Yes. Hello? Anyone? Hello?
I think
Yes,
this
please.
is covering the
So the visceral,
organ. Okay, go ahead,
Next,
Dr.
Okay. Please
visceral is
participate
lines
because
and parietal
okay.
lines the
Okay. So visceral peritoneum basically lands your viscera. For example, your hollow organs are basically your viscera, right? So this is going to be like in the structure here. You guys can see this is going to be your visceral peritoneum, right? And then you have your parietal peritoneum. Here you guys can see it basically lines the inner most aspect of your abdomen, right? So we have two layers of peritoneum, right? That's important that you guys should know. Okay. What's the main difference? Which kind of UWorld MCQ are you going to see? That's basically related to pain. For example, if we have irritation of visceral peritoneum, so can you guys just tell me which kind of pain are we going to expect in that individual? Yes.
Back pain.
Okay, it would be vague pain. Perfect. Can we just localize the pain, or it would be a diffuse kind of pain? What do you guys think?
Diffuse.
Diffuse.
Perfect. So it would be diffuse pain. You cannot like localize the pain. And for example, if we have, or if certain individual have like irritation of their parietal peritoneum, so what do you think? Which kind of pain are we going to, this guy is going to experience? Would it be sharp pain? Would it be vague pain?
It's gonna be sharp, localized pain.
Okay, perfect. Sharp, localized pain, like we can localize. So you have a U-word MCQ, like for example, you're going to have individual, like for example, if you have an individual, he had like appendicitis, and that appendix is, like irritating your parietal, like peritoneum. First of all, the pain was vague, but right after some time it became sharp. So what do you think? Basically, the idea and the concept is that now your appendix is basically irritating your parietal peritoneum. That's why the pain have transitioned from the vague to more sharp and localized pain. Is that clear?
Yes,
Okay.
sir.
This is going to be the take-home concept which you guys should know. Okay. So the visceral peritoneum further is going to, like it have different layers. It's going to be like, becoming folded at certain point, which will give rise to omentum. That is your greater omentum and lesser omentum. So here you guys can see this is going to be your greater omentum. It's going to be covering different aspects of your small intestines. Here you guys can see this is your greater omentum and your lesser omentum here. Basically, these are the foldings of your visceral peritoneum. Is that clear? Okay, so there are different structures which are present retroperitoneal, right? You guys should know that. And basically, the mnemonic used for that is Sedgwicker, right? But we won't use that mnemonic. We are going to, think of individual structures, that which structures are retroperitoneal. So starting from esophagus. So what do you guys think? Which structure or which part of your esophagus is retroperitoneal? Yes.
The thoracic part.
Perfect. So thoracic part of your esophagus is basically retroperitoneal. Let's just come down. What do you guys think, like in duodenum, like which parts of duodenum are retroperitoneal?
Second through fourth parts.
Okay, so the second and the third part of your duodenum basically are retroperitoneal. Is that clear? Okay, let's discuss colon. What do you guys think? Which, like a segment or which part of your colon are basically retroperitoneal structures? What do you think?
They descend, ascending and descending.
Ascending and descending.
Descending. It means the transverse colon isn't retroperitoneal. Okay. What else? Let's discuss. Okay, let's come a little bit down. That is pancreas. So what do you think? Is pancreas a retroperitoneal structure, or some of the parts of pancreas are retroperitoneal? What do you think?
It's
All parts of the
It's not
pancreas. All parts
retroperitoneal.
of the pancreas except the tail.
detail.
Perfect. So all parts except the tail, they are retroperitoneal. And what do you think about the rectum?
Part of the rectum is retro, and
Okay,
part
which
is
part?
Partially retroperitoneal and partially not.
Okay, so the upper
Upper.
2/3 is basically retroperitoneal. Okay, what else? What do you think? Aorta, is aorta retroperitoneal structure or not?
Yes.
retroperitoneal. Yes.
Okay, aorta plus your inferior vena cava is also retroperitoneal, right? And for the kidneys, we already know that kidneys are also your retroperitoneal structures. Along with that, the ureters are also your retroperitoneal structures, and the adrenal glands as well, because they sit on the top of your kidneys, right? Adrenal. Okay, so these were all about retroperitoneal structures. So you will be asked a lot of questions regarding these retroperitoneal structures. Like for example, if you have an individual, you have like acute like pancreatitis, and as a result of that, like there is rupture of an artery, which we will be discussing the entire arterial supply in a while. So what do you think? The blood is going to be accumulated in the retroperitoneal structure. As you guys already know that most of the component or most of the part of pancreas are retroperitoneal. So these kind of questions are going to be asked on your viewer as well as NBAs. Is that clear? So you must be aware that which structures are basically your retroperitoneal structure. Is that clear? Hello?
Yes.
Yes,
Okay,
sir.
perfect. Perfect. So let's discuss our next topic, that is ligament. Basically, we know ligaments attach bone to bone, but here we already know that basically here the viscera, the visceral organs are attached to one another, and basically we also call them ligament as well, right? So there are different ligaments. I'll be just marking those ligaments, and you guys are going to tell me the name. What is the name of this ligament? What do you guys think?
Falciform ligament.
Ligament.
Okay, it's falciform ligament, right? And the falciform, okay, what are the content present within the falciform ligament?
Ligamentum teres.
Okay, ligamentum teres, right? Okay, so the ligamentum teres is basically present within the falciform ligament. Okay, what about this ligament? What's the name of that?
Hepatoduodenal ligament.
Okay, perfect. Hepatoduodenal. Why? Because it's connecting the liver with your duodenum. So we are going to simply call it as hepatoduodenal ligament. And what are the content? Very high yield. I would say, like in this discussion, the most high yield ligament is, I would say, hepatoduodenal.
Portal triad.
Okay, perfect. Portal triad. So what do portal triad include?
Portal
The
vein, hepatic artery,
they-
and common
yes.
bile duct.
From the bile
Yes.
Okay,
duct.
perfect. We have portal vein, we have common bile
Bile
duct,
duct.
and we have
Hepatic artery.
proper
Artery.
hepatic artery, which we are going to discuss in a while. Okay, so basically we have a manure which is known as Pringle manure. So who is going to tell me what is Pringle manure and what's the significance of this manure? Yes.
It is used as it is clamped during surgeries to control the bleeding.
Okay, perfect. For example, if we just clamp this ligament during surgeries and still we have bleed, so what do you think this bleed is coming? What do you suspect this bleed is coming from? Which source?
Inferior vena cava.
Okay, either inferior vena cava or
Hepatic veins.
hepatic veins. Perfect. Okay, so we have a manure, that is Pringle manure. What do we do in Pringle manure? Basically, we are going to clamp off this ligament, and as a result of that, we are going to make sure that either, for example, if we have hematoma, like, or internal bleed, so we are just making sure that either the source is like from the portal vein or it's from hepatic artery. If we just, like, clamp off this ligament, and if the bleed stops, simply you can think of that these are most commonly going to be the source of this bleed. But still, if the bleed continues, so we are going to simply assume that it might be coming from inferior vena cava or hepatic vein. So this is basically Pringle manures. Is that clear?
Yes.
Okay, perfect. So I'm going to mark another ligament. You guys are going to tell me the name of that. What's the name of this ligament?
Hepatogastric.
Okay, it's
Hepatogastric.
gastrohepatic ligament, right? Gastro. Okay, let me just write it down here. Gastrohepatic ligament. Okay, can you just tell me the content of gastrohepatic ligament? Those who have just done a little bit of blood supply, so they'll just answer me. Which
Gastric
artery basically?
vessels. Gastric
Yes.
Oh
vessels.
yes, gastric vessels, right? Gastric vessels. We are going to discuss it in detail. Okay, perfect. What about this ligament? What do you think? What's the name of this ligament?
Gastrocolic.
Okay, perfect. Gastrocolic. That is your like, it connects your stomach to your colon. So simply it's going to be known as gastrocolic ligament. And what do gastrocolic ligament contain?
Gastroepiploic vessels.
Okay, right gastroepiploic vessel, which we are going to discuss, right? Right gastroepiploic vessels. Perfect. And the last ligament, what's the name of that?
Gastrosplenic.
Okay, gastrosplenic. And what are the content of gastrosplenic ligament?
Short gastric.
Okay, short
Left
gastric, which are basically going to supply the fundus. Okay, and what else? Left gastroepiploic vessel, which is branch of your splenic artery. Okay, so this was all about ligaments. So okay, so let's discuss a little bit about innervation, right? So as you guys are already aware that the gut is basically supplied, like, it have two kinds of innervation, the parasympathetic and sympathetic, right? So you guys are going to tell me that for the parasympathetic innervation, starting from the foregut till your midgut, what do you think which like nerve is going to supply the parasympathetic, or what's the which nerve basically supply? What do you think?
Vagus.
Okay, perfect. So basically the foregut plus midgut get their parasympathetic innervation from their vagus, right? And for the hindgut, the parasympathetic innervation basically comes from, yes,
The pelvic splanchnic nerves.
okay, pelvic splanchnic nerve from S2 to S4, okay? So we are already aware of the fact that parasympathetic basically comes from two sources, right? Either in your cranial aspect, that is basically the craniosacral, right?
Yes.
And thoracolumbar for your sympathetic. We already know from the thorax and from the lumbar, we are going to have sympathetic nerves coming out, and craniosacral are basically for the parasympathetic, right? So the vagus nerve is going to supply the foregut and midgut, while the hindgut is going to be supplied by the, the pelvic splanchnic or the sacral portion of the spinal cord, right? Okay. What about the sympathetic innervation for the foregut and midgut?
From the lumbar.
Okay, from the lumbar or thoracic region. What do you think?
And it's from the thoracic and lumbar, from both.
Okay, from the thoracic region, right? That is T5 to T12. And for the hindgut, it basically comes from the lumbar splanchnic nerve. That is L1 to L2, right? So we are already aware that, for example, the craniosacral, basically from the craniosacral aspect of your spinal cord, we have parasympathetic and the thoracolumbar for sympathetic. You already know that, right? So simply you can imagine that the upper portion is going to be supplied by the vagus, while the lower portion is going to be supplied by the sacral branches, okay? And similar, the upper portion, that is the foregut and until the midgut, again, for the sympathetic supply, is going to come from your thoracic region, while for the hindgut, the sympathetic supply is going to be coming from your lumbar region, right? Is that clear?
Yes, splanchnic and the celiac plexus.
Yes. Okay, perfect. So let's discuss a little bit about the blood supply, right? So blood supply is very important, and okay, just give me a second. So the blood supply is very important. So for example, this is our, let's suppose our abdomen. So you guys are going to be naming the branches. I'll just note down, and you guys are going to tell me the name of those branches which are coming out from your abdominal aorta, okay? So this is going to be your diaphragm, okay? Diaphragm. So what do you guys think? What's the, okay, so I'm just drawing it. What's the name of this branch of abdominal aorta? Perfect. It's your celiac
Trunk.
Perfect. Okay.
Trunk.
What about these branches?
Superior mesenteric.
Okay. This is
No.
going to be your celiac trunk.
Yeah.
Okay. This is going to be your renal.
Renal,
branch,
yes.
right?
Superior suprarenal.
Okay.
Yeah.
This is your
Renal.
superior
That's
mesenteric.
SMA, yes.
It's just
SMA,
below.
okay.
Yeah,
So your
celiac.
celiac trunk, your SMA, your renal. What about these? These small branches?
Gonadal, left gonadal.
Okay, gonadal, perfect. Like in case of female, it would be ovarian, and in case of male, that would be like testicular. Okay, and what about this one?
IMA.
Inferior.
IMA,
Superior mesenteric.
perfect. Inferior mesenteric, and these are your common iliac. Already you guys know that common iliac and branches of common iliac, that is external and internal.
Internal,
So this is going to be
external.
internal and external
Internal.
branches. Okay, so you guys already know that celiac trunk basically supplies the structures of your foregut, right? While the SMA, that is superior mesenteric artery, basically supplies the structures, most of the structures of your midgut, while the hindgut is supplied by IMA, that is inferior mesenteric artery, right? So let's discuss celiac trunk first in a little detail, right? Okay, so okay, let's discuss it here, right? So the celiac trunk. So we already discussed that celiac trunk is going to be supplying the structure of your foregut. So what are the structure of your foregut? We already know that esophagus, your stomach, your liver, gallbladder, and spleen. Let me repeat it again. Esophagus, stomach, liver, gallbladder, and spleen. We already know that they are parts of your foregut, right? They are structures of your foregut. Okay, and some part of the duodenum as well, duodenum and pancreas as well, as we'll be discussing, right? So this is going to be your celiac trunk. Okay, let me just draw it with black pen. So this is your celiac trunk. So celiac trunk, first of all, is going to give 3 branches. Here you guys can see one branch which is running towards the spleen. So let me just name it as splenic branch, right?
Yeah.
Splenic artery. Splenic artery. Okay, so then you have your other branch, which is basically coming to the left side, supplying this lesser curvature. What do you think is the name going to be?
Left
Left gastric.
Left
gastric artery.
gastric, right? Left gastric artery. Perfect. Left gastric artery is also going to give some branches to your esophagus, which are going to be your esophageal branches. Okay. Okay. So the third branch is going to be your
Common
yes. What's the name of-
Common hepatic.
Perfect. Your common
hepatic.
hepatic. It means that you have common hepatic. So common hepatic is further going to be divided into several branches, right? So the common hepatic further is going to divide into yes, this one. What's the name of that?
Duodenum.
Okay, perfect. Gastro duodenal.
Yeah.
Okay. Okay. So the gastroduodenal here, you guys can see it is going to give like two other branches that is like wrapping around your greater curvature. And what would be the name of that? It's right.
Gastroepiploic.
Right, this
Yes.
is
Gastro
Epiploic artery.
epiploic. Perfect. So you have left gastroepiploic as well, which is basically coming from the splenic artery. So can I just draw it like that?
Yes.
Okay, perfect. So you have left gastroepiploic, and here you guys can see simply it's coming from the splenic artery. Is that clear?
Yes.
Okay, perfect. So as you guys can see that both of these vessels are basically anastomosing, right? And it's very important. Like for example, due to thrombus, let's suppose if this part is blocked, so now you have like the second pathway which can perfuse the structure. So anastomosis is very important, right? So this is going to be your gastroduodenal artery, the right gastroepiploic. And what's the name of this branch? What do you guys think?
Superior pancreatico-duodenal.
Perfect. Superior pancreatico duodenal, right? So if you have superior pancreatico-duodenal artery, so there must be inferior pancreatico-duodenal artery as well. So what do you guys think inferior pancreatico-duodenal comes from where? What do you
SMA.
guys think? SMA, perfect. And again, they are going to anastomose, right?
yes.
With one another. So this is going to be the gastroduodenal. The branches are right gastroepiploic and superior pancreatico-duodenal. Okay. So let's discuss our the next branch of your common hepatic, which is your proper hepatic, right? So this is going to be your proper hepatic artery. And proper hepatic artery in turn would just give a branch, yes, which is going to come along your lesser curvature, joining the left gastric artery. So what do you guys think? What would be the name of that?
Right
If it's
gastric.
left,
Right gastric.
yes, if it's left, it's going to the one coming from the proper hepatic should be right, right? So it's going to be right gastric artery. Okay. And further it's going to like move up and it's going to give three branches, right? One branch to your right lobe, which is going to be right hepatic artery, your left lobe, left hepatic artery, and one to your cystic artery to your gallbladder, right? Cystic.
Yes.
Cystic artery. Is that clear? Okay. So here you guys can see an important point which we haven't mentioned. So the splenic artery is also going to give some small 5 to 6 branches to the fundus of your stomach. This is your fundus, right? Okay. So you guys can see that the fundus basically there isn't any kind of anastomosis. Like at the greater curvature, we can simply see the anastomosis, and which was helpful, for example, if we have some thrombus, right? So the blood can come all like in the second pathway here, like for example, if we have blockade of the splenic artery, still blood can come through the through the gastroduodenal and the right gastroepiploid. But the most vulnerable part for ischemia is going to be that part which do not have anastomosis. So here you guys can see that the short gastric arteries, which are basically coming from the splenic artery, do not have anastomosis, right? It's going to supply the fundus. So can I say that fundus is going to be the most prone part of your stomach towards ischemia? Can I say that?
Yes.
Okay, so it's prone to ischemia, right? So it was all about your celiac trunk. Let's just revise this, okay? So you guys are going to be telling me, I'll be asking you some questions, and you guys are going to be telling me the different branches, because as we keep on revising again and again, Then we are going
Hello,
to,
sorry, sorry, doctor. Hello.
Yes, please.
Can you explain why the fundus is the commonest? I mean, is the commonest part of ischemia? I didn't get that
Okay.
point.
Okay. As we discussed that here, you guys can see that at the greater curvature, we have anastomosis between the right gastroepiploid and left gastroepiploid, right? So for example, if the splenic artery is compromised, right? Still, this greater curvature can take blood from this branch, the gastroduodenal, through the right gastric, right? Due to anastomosis. Is that clear? But
Yep.
the short gastric do not have anastomosis. Anastomosis simply means it do not have second pathway for the blood to come and feed there. It do not have anastomosis. So if we have like blockade or we have compromise of the splenic artery, so the fundus is going to be prone to ischemia because it do not have like another pathway for the blood to come there, right? Is that clear
Okay,
now?
okay. Yeah,
Okay,
thank you, sir.
Perfect. So let's revise these branches and I'll be asking from you guys. So Dr. Amiz is going to be telling me main branches of celiac trunk. Yes.
Okay, so there are three main branches of the celiac trunk.
Okay.
First is splenic artery and
Okay.
the left gastric artery and the common hepatic artery.
Okay, the common hepatic, left gastric, and splenic, right? Okay, Dr. Satrov is going to tell us branches of common hepatic artery.
The common hepatic artery that's gonna come through from where is coming the two branches. So one is the left gastric artery that supply side of
proper hepatic and gastroduodenal.
Yeah, that supply the body of the stomach.
Okay, perfect. So let me just repeat it again. We have like celiac trunk, it's going to give like three main branches, that is splenic, second common hepatic, and third, what's third? Left gastric, right? Branches of common hepatic, there are two branches of common hepatic. What's that? As we have drawn here, the two branches of common hepatic are going to be your proper hepatic and gastroduodenal. So Dr. Daniela is further going to tell us branches of proper hepatic artery.
For proper hepatic artery?
Yes.
Is that not the one that gives rise to the gastroepiploic artery? The gastroepiploic.
Gastroepiploic? Or you have right gastric?
Right gastric.
Right gastric.
Oh, right
okay,
gastric.
So
right
let
gastric.
me just give you an overview again. Okay, let me just give you a quick overview. Let me just erase all of these branches and give you now we saw that. Let's clear it again, okay? So as we discussed that we have three main branches coming, that is one which is feeding your spleen, which is your splenic artery, right? Okay. Then we discuss our next artery, which is your left gastric, right? Which is feeding the short or the lesser curvature of your stomach, right? And it's also going to give branch to your esophagus as well, okay? What else? The third branch is going to be your common hepatic. So we have three main branches of your celiac trunk: splenic, left gastric, and common hepatic. Common hepatic is further divided into two branches. The common hepatic further divides into two branches. Here you guys can see the gastroduodenal and proper hepatic. Is that clear? Two branches from your common hepatic, gastroduodenal and proper hepatic. Gastroduodenal further is going to be giving two branches: your right gastroepiploic, and superior pancreatico-duodenal artery. Is that clear? And further, your proper hepatic artery is going to give your right gastric as well as three further branches, one to your right lobe, to your left lobe, and to your gallbladder, that is cystic artery. Is that clear? These are the entire branches. What about splenic? Splenic is going to give, like it's going to feed your spleen. Further, it's going to give short gastric arteries and your left gastroepiploic. Is that clear? And here you can see, and that's the entire blood supply, right? There's nothing
yes,
like,
I got it.
Okay. So let me have a
Should I repeat
Q&A
it?
session again, right? So now I'm expecting a lot.
Okay, yes, okay, yes.
Okay, so Dr. Daniela, okay, let's start from beginning. Okay,
Okay.
Dr. Margaret, can you just please tell me the 3 main branches of your celiac trunk?
There are splenic artery, left
Okay.
gastric artery, and
Perfect.
common hepatic.
Perfect, that's perfect. Dr. Satrov is further going to tell us 2 main branches of common hepatic.
Right gastric artery and common hepatic.
Common hepatic, perfect. Dr. Daniela is now going to tell us 2 different branches of gastroduodenal artery.
That's the gastroduodenal. That's the right gastroepiploic and the superior pancreatoduodenal.
Perfect. And Dr. Kenana is going to tell us the branches of proper hepatic artery.
Yes, sir. So it gives the left hepatic, the right hepatic, and the cystic artery.
What else? You're
So
missing one main,
Right gastric.
Perfect.
Right gastric, yeah.
Yes, where is
Right
Dr. Muskan? Dr. Muskan, are you here?
Yes,
Hello?
doctor. Here.
Okay, perfect. So Dr. Muskan is going to tell us different branches of splenic artery.
Yes. So left gastroepiploic artery and short
Okay.
gastric artery.
Short gastric artery. Okay, why the short gastric or the fundus is prone to ischemia? What do you think?
Because I think there
There isn't any anastomosis.
Yes.
Okay, perfect. So this was all about celiac trunk. It's like a little bit, confusing, and all of the other blood supplies, they're simple, right? So sometimes we have perforated ulcers, right? So like it's not common nowadays, but if we have perforated ulcers at lesser curvature of the stomach, so what do you think, for example, if it perforates, so which artery is going to bleed into your stomach? What do you think?
Right gastric artery.
Right
It's
gastric.
going to be your left gastric artery, remember, right? Left
Mhm.
gastric.
Left
Whenever
gastric,
we
okay.
have perforated ulcers at the lesser curvature, the artery which will just bleed into the stomach is going to be your left gastric artery. Is that clear? Okay, if we have perforated ulcers at the posterior aspect, or that is at the greater curvature, what do you think which artery? Okay, the posterior, okay, so sorry. If we have posterior duodenal ulceration, so what do you think which artery is then going to be involved?
Gastroduodenal.
Gastroduodenal. Okay, so your gastroduodenal is going to be involved. Okay, so we discussed Pringle manures and we discussed the different branches. Okay, so let's discuss our SMA, that is superior mesenteric artery, right? SMA. So Dr. Muskan is going to tell us SMA is going to supply which part of your gut? Yes.
Foregut.
Okay, foregut.
Sorry, midgut. I'm sorry. Sorry, mid.
Okay, midgut. Can you just tell me different structures of midgut?
Yes, doctor. It
Starting
includes
from
all
the distal duodenum, yes.
Yes, distal duodenum, then ascending colon. Yes.
Okay.
Duodenum,
Okay.
ileum.
Ileum,
Yes.
cecum.
Cecum. Yes. Ascending colon. Then proximal 2-3 of the transfer colon.
Perfect. Till proximal 2/3 of transverse colon. All of these structures are going to be supplied by SMA, superior mesenteric artery, right? Okay, so here you guys can see this is going to be your superior mesenteric artery. And if you guys remember, we discussed that this is going to be, okay, what's the name of this branch? As we discussed, superior pancreatic or duodenal artery, remember?
Yes.
Yes.
Okay.
Yes, sir.
And we discussed that we have inferior pancreatic or duodenal artery as well, which comes from SMA. So this is going to be your inferior pancreatic or duodenal artery, and both of them are going to join like that. It's going to supply the head of your pancreas. Okay. So SMA basically come above here. You guys can see above your duodenum, right?
Yes.
Okay. And it's very important, right? Sometimes you can have a syndrome which is known as SMA syndrome, which we'll be discussing in a while. So you guys should know that SMA basically courses above your duodenum, right? So sometimes if we have problems, it can impinge or it can obstruct the duodenum, giving a small bowel obstruction. Okay. So here you guys can see different branches of your SMA. So SMA is going to feed like this is going to be the ileocolic branch, the ileocolic. This is going to be your right colic, and this is going to be your middle colic, right? So you have three main branches. That is the right colic, the ileocolic, and the middle colic. And along with that, these branches you can see which are basically supplying the jejunum and the ileum. They're simply going to be called as ileal and jejunal arteries. Is that clear?
Yes.
Okay. So let's just discuss it again. So we have superior pancreaticoduodenal SMA coursing above your duodenum is going to give right ileocolic, your right colic, ileocolic, middle colic, and ileal and jejunal arteries. Is that clear? And in this way, it's going to supply the entire midgut. Okay, so here you guys can see if we zoom in the picture of your jejunal and ileal artery. So basically, they are going to form certain structures which are basically no. Okay, here I have we have the structure here. So you guys can see it's basically like forming anastomosis. Here you guys can see like a lot of anastomosis, right? So these
Yes.
anastomosis, like you can see, they are in the form of U-shaped structure. So they are basically called as arcades, right? Arcades. And the arcades further are going to give branches which are going to distally supply the jejunum and ileum. And these branches which are coming out of your arcades are simply called as vasa rectas, right?
Yes.
Okay, so these are your vasa recta. So arcades are basically, here you guys can see your arcades and vasa recta, which are going to feed your distal portion or portions of your jejunum and ileum, right? So this was all about SMA. So sometimes you can have a syndrome which is known as SMA syndrome. So as here we discussed that the SMA, superior mesenteric artery, basically courses at the distal 1/3 of duodenum. So this is going to be distal 1/3. It courses above your distal 1/3 duodenum, right? And in between here we have a fat pad, a pad of fats present here, right? Which is basically avoiding the SMA to obstruct your duodenum. For example, if you have an individual, he's having excessive weight loss, and what if this fat pad is lost during his fat loss journey, let's suppose, right? So now what happens, your SMA is going to impinge or it's going to obstruct your duodenum, and it will just give you signs and symptoms of obstruction. Is that clear?
Yes.
Okay, so what happens in between SMA and aorta, the duodenum is going to be obstructed. If you guys remember, we have a similar kind of effect, the nutcracker effect. Remember?
Mm-hmm.
Do you guys remember the nutcracker effect
Yes.
in the renal
Yes.
section? Okay, what was your red nutcracker effect? Who's going to tell me that?
In the nutcracker, the left renal vein is basically
Okay.
compressed between the SMA and the aorta
Okay.
because the
Okay.
renal vein is passing behind the SMA and
Perfect.
it can be compressed.
And we were also seeing the left-sided varicocele due to anatomy, right? Gonadal
Yeah.
veins directly draining into left renal vein, if you guys remember. That was an important point, right? Okay, perfect. So let's discuss our last blood supply, which is going to be your IMA, right? So IMA, basically, the inferior mesenteric artery supplies your hind gut structure, right? Hind gut. Okay, so you guys are going to be telling me the different structures which comprises the hind gut.
Distal 1/3 of the transverse colon.
Perfect. What else?
Descending colon.
Upper portion of
And
renal canal.
okay, perfect. Like till sigmoid colon. Okay.
Yes.
So they're going to be supplied by inferior mesenteric artery. So here are some of the branches. Your left colic. You guys can see this is going to be your left colic branch, which is going to supply the structure. We have sigmoid arteries here. So sigmoid and left colic are going to be supplying these structures. Okay. So this was all about the blood supply of your GIT, and we have a lot of your MCQ on that. So hope so you guys now know a little bit about blood supply, right? Okay. So this was all about blood supply. So an important discussion, our last discussion, which we are going to have here is veins and anastomosis, right? Can you just please fix your mic, Dr. Victor? I'm just, having some issues, although my voice is echoing. Okay, thank you so much.
I have a
So,
question.
yes, please.
How do you differentiate, let's say in the questions when they ask you, whether it is the superior mesenteric or the inferior mesenteric? How do you differentiate that? Because I had a problem.
Okay, so like I didn't get you like how to differentiate inferior mesenteric and superior mesenteric arteries.
Yes.
It's simple. You can just look for the peripheries which these arteries are supplying, right? If in the question you have like something related with your ascending colon, so think of that it's going to be supplied by your, if you have problems like for example appendicitis, if you have like scenario on that, something related to cecum, the branches or the peripheries which these blood vessels are supplying, thinking of that, you can simply know that either they're fed by this SMA or IMA, right? And although we are going to have discussion on UWorld as well, right after we end this class, we are going to just please come to the Discord. Yesterday you guys weren't there, and we're going to have discussion. So in the UWorld discussion questions, we are going to make it more clear, right?
Okay.
Okay.
Thank you.
Okay. So let's discuss our portal venous system and our systemic venous system. So all of you guys are aware that we have two kinds of venous systems within the gut or normally within the body. The portal venous system and your systemic venous system. And these venous system basically anastomose at different specific locations. If you guys are aware of that, it's a common topic. Everyone know that, right? So but whatever we eat or whatever, let's suppose if we just ingest some drugs or some poisons, so all of these, the blood or all of these content are first of all going to be drained into portal veins. You guys know that, right? Is that clear? So let's discuss portal vein in a little bit detail, right? So this is going to be our portal vein. And the important point which you guys have to know that which other vein feeds your portal vein. So I'm going to be like, drawing I'm going to be marking the structures and you guys are going to be telling me the name, right? So this is going to be your portal vein. Okay, can you guys just tell me the vein which I'm marking? What's this vein? What's the name of this vein?
Splenic vein.
Perfect. So it means that splenic vein is going to feed, it's going to drain into portal vein, right?
Yes.
Okay, what about this one?
It's a superior mesenteric vein.
Perfect. Superior mesenteric vein. So it means that superior mesenteric vein is directly going to drain into portal vein. What about this one?
Inferior mesenteric.
Inferior mesenteric.
Perfect. Inferior mesenteric vein. It means that inferior mesenteric vein do not directly drains into your portal vein, while first of all it's going to drain into splenic vein, and then the blood is going to be drained collectively into portal vein. Can I say that?
Yes.
Okay, perfect. So we know that these portal veins are going to be anastomosed with your systemic vein at different points, at specific points. So you guys are going to be telling me the three anastomosing or the three joining points of the portal veins with systemic veins. Yes.
Sorry, can you say again, please?
Okay. My question, okay, so my question is that the portal veins and your systemic vein anastomose at three different locations, right? So for example, if someone is having liver failure, if he's having portal hypertension due to that, so these anastomosing points are going to be enlarged, right? You are going to have a venous blood or a tuft of blood present there. Three specific locations we have anastomosis of portal venous system with systemic veins. You guys are going to be telling me that three main important or three specific points.
The esophagus, umbilicus, and rectum.
Esophagus.
And left gastric.
Umbilicus.
Okay.
The rectum.
Esophagus, umbilicus, and
Rectum.
the rectum, right? So in the esophagus, in the lower esophagus, basically the left gastric vein, which is basically your portal vein, branches of your portal vein is going to be anastomosing with your esophageal veins, systemic veins, right? And for example, if someone is having portal hypertension, we are going to see esophageal varices there, right? Like a big enlarged tuft of these anastomosing point, which can easily rupture, which can lead to death. You already know that, right? Hello?
Yes.
Okay, perfect. At the umbilicus, the para-umbilical vein are going to be anastomosing with your small epigastric veins, giving you a characteristic structure, caput medusa, right?
Yes.
Like it can, yes, it can be imagined like different like snake-like structures coming out from your umbilicus, that are basically known as caput medusae. And what about rectum? At the superior rectal vein is going to be anastomosing with inferior and middle rectal vein, giving you anorectal varices. Is that clear?
Yes.
Okay, perfect.
Doctor, can you just
So,
repeat the can you repeat the veins of the anastomosis?
okay, no problem. So in the esophagus, we discussed that basically your left gastric vein, left gastric. Here you guys can see the two branches, your gastric veins, which are basically branches of your portal veins, right? So the left gastric from the portal veins are going to be anastomosing with your esophageal veins, right? And if we have enlargement there due to portal hypertension, it's going to form esophageal varices, right?
Yes.
Yes, right.
For the umbilical, we have para-umbilical vein, which again are some branches or from your, like it's basically going to be the portal branches, the portal vein branches aspect. They're going to be joining with the small epigastric veins, which are systemic veins, right? With small epigastric veins. And the last, you have superior rectal vein. Again, the portal vein aspect of your anastomosis joining with inferior and middle rectal vein. And again, it will be giving us anorectal varices in case of portal hypertension. These three areas are going to, simply you can say they are going to enlarge. They're going to be filled with the venous blood, right? Giving us caput medusa in case of umbilical region. In case of the rectal region, it's going to give us anorectal varices. In case of the lower esophageal region, it's going to give us esophageal varices. Is that clear?
Yes.
Yes.
Okay, perfect. So the last discussion of today's lecture is going to be hemorrhoids, right? So can you guys just tell me what are hemorrhoids? Yes.
Engorged.
There are two types, internal and external.
Perfect. Internal and
Enlargement
external.
of the
I'm asking.
veins.
Okay, perfect. So can I say that it's they are going to be engorged venous structures, right, or engorged veins filled with a lot of venous blood? Like they can appear, for example, if someone is performing Valsalva maneuver. So again, these venous they can just enlarge, they can protrude out, or someone is like attempting to have a bowel. So in that cases, what happens? These hemorrhoids are going to appear, right? So basically, we have two kinds of hemorrhoids: internal hemorrhoids and external hemorrhoids, right? So we have a line which is basically known as pectinate line, right? So above the pectinate line, basically we are going to have internal hemorrhoids, and below the pectinate line, we are going to have external hemorrhoid. So basically, there are different features how to differentiate internal from external. So I think most of you guys know. So I'll be asking you some questions. Which hemorrhoids are going to be painful? Internal or external, and why?
External.
External are going to be painful. Why?
Because the
To see the somatic innervation, yeah.
Perfect. Somatic innervation via which nerve? Pudendal nerve, right?
Pudendal nerve, yeah.
Perfect. Okay. Internal hemorrhoids are painless. Why?
Because it's
So the
visceral
visceral innervation.
Okay. Because they have visceral innervation, right? Pelvic splanchnic nerve, as we already discussed. Okay. Can you guys just tell me that the epithelium present above the dentate line and below the dentate line, the epithelium was also different. Above the dentate line, what's the epithelium present?
Columnar epithelium.
Simple columnar epithelium. Perfect. Below the dentate line?
squamous.
Squamous epithelium. Perfect, right? So these were all about hemorrhoids, and you're going to see some MCQs like if we have an individual, you have hemorrhoids, they are painful. So simply you'll be answering. They'll be asking you that what's the like either the nervous supply, or they'll also be asking that either what's the like the region, or what's the region there basically have which kind of epithelium, right? So these are the questions which you guys are going to be asked, right? So this was all about today's lecture, and we have finished off the embryology along with anatomy. Tomorrow we are going to discuss the entire physiology, right? And day after tomorrow will be starting starting our pathology. Yes, please.
Dr. Ahmed,
Yes,
can you
please.
just come again about the epithelium? I didn't quite get that. Below below is what?
Oh, perfect. Below, basically, you have your non-keratinized squamous epithelium. Non-keratinized squamous epithelium. And above, you have simple columnar epithelium. Is that clear?
Yes, thank you so very much. Yes.
Dr. Ahmed?
Yes, please.
Can you please repeat the parasympathetic and sympathetic supply of GIT?
Okay, no problem. So actually, we discussed that GIT, the GI tract basically is supplied by both sympathetic and parasympathetic, right? So normally, remember, okay, let me just give you a small overview of that. Remember, the parasympathetic comes from two locations. Remember that, right? The cranial aspect and the sacral aspect, right? From the cranium, like for example, with cranial nerve 3, we already know a parasympathetic supply, while like the Edenger-Westphal nucleus, if you guys remember. Simply the vagus nerve also coming from the cranial aspect down. Do you guys remember that? The vagus,
Yeah.
10 cranial nerve from the brainstem coming down. Okay?
Yeah.
Simply from the sacral aspect as well. From the sacral aspect, the pelvic splanchnic nerve, and it's going to supply different structures, right? Similarly, the sympathetic nervous system is going to come from the, like for example, if this is your spinal cord, it's going to be coming from two regions, right? Either thoracic region or the lumbar region. Is that clear, Dr. Muhammad?
Okay.
Is that clear till now? Okay, let me just repeat it, okay? So you should think of the parasympathetic only either come from your cranial aspect, from your brain, or from the sacral aspect, these two areas. And the sympathetic comes from thoracic and lumbar. So now let's discuss the GI tract, right? So we have our foregut, our midgut, and our hindgut. Remember, foregut and midgut are basically present, like on the upper aspects, right? On the upper aspect. It means that the sympathetic would be coming from the upper aspect via vagus nerve. Or the parasympathetic would be coming from the upper aspect, the cranial aspect, via vagus nerve. While the sympathetic would be coming from the thoracic region. Is that clear? While for the hindgut, the parasympathetic would be coming from the sacral region, and the sympathetic would be coming from the lumbar region. Is that clear?
Okay, I get it. But why parasympathetic comes from the cranial and sacral region, and sympathetic comes from thoracic and lumbar region?
Okay, it's it's a rule of thumb. Okay, simply you just remember that. Okay, because the sympathetic trunk is present here, right? If you have you done the neuro module?
No, I joined.
Okay.
Now.
I think you have missed that. No worries, right? So we discussed in neuro in a big detail that we have sympathetic, which are basically okay. For now, simply remember thoracolumbar for sympathetic, craniosacral for parasympathetic. Cranio and sacral for parasympathetic. Parasympathetic come from the cranial or the sacral aspect. Simple. Sympathetic come from thoracic and lumbar because it's due to anatomy, right? All of the anatomical structures are present here.
Okay. Thank you.
Doctor, can you just mention the root values for the sympathetic supply of the gut, that is thoracic and the lumbar splanchnic nerves? What are the root values you said?
Okay, so no problem. So for the hindgut here, okay, so for the cranial, we discussed its vagus nerve, right? Is that clear? But the parasympathetic for the hindgut comes from S2 to S4. Is that clear?
Yes.
Thoracic comes from T5 to T12, while lumbar, it comes from L1 to L2. Is that clear?
Yes.
Okay, perfect. So that was all about anatomy. So tomorrow we are going to start physiology. We'll be doing. Okay, so I'll be sharing schedule in a while. Just please go to the Discord server and please do have discussion. Okay, yesterday I was just expecting you guys would be there, but I don't know what happened. But today is just please, Okay.
Excuse me, Doctor.
Yes, please.
I have a question. Maybe it's a little bit funny, like about the foregut, and the part of the foregut. It's a pharynx, lower respiratory tract.
Okay, sorry. What's the question?
About the foregut.
Okay, so the foregut. Okay.
The part of the foregut that gives rise to, pharynx and the lower respiratory tract, esophagus and stomach, proximal duodenum, liver, biliary apparatus, and pancreas. And the question is that how the part of the respiratory system, the lower respiratory system, is derived from foregut.
Okay. So if you remembered in the respiratory section, we discussed it in detail, embryology, right? So what happens that the foregut basically is going to give us a diverticulum, which is known as respiratory diverticulum. Did you remember that lecture?
Yes.
So basically your respiratory system comes from your foregut, right? So this respiratory diverticulum in future is going to be developed into your mature lungs, right? So there are different stages. The mnemonic for that was, if you guys remember, every pulmonologist can see alveoli. Remember? Embryonic stage, P4, okay, pseudoglandular, secular. Yes, what else? Can see alveoli, canalicular and alveolar. Okay, so what happens now when the fetus is like is in, like, if you have a fetus within the uterus, what happens? The amniotic fluid is going to be aspirated, and due to aspiration of that amniotic fluid, this respiratory diverticulum is going to be pushed forward. It's going to be stretched, and then it's going to form the proper structure, the proper mature structures of lungs, right? So basically, these structures come from your foregut as a respiratory diverticulum. That's why they're a part of foregut. Is that clear?
Yeah, thank you so much.
Okay, thank you. So hope so you guys enjoyed the lecture, and thank you so much, and see you tomorrow. Okay, thank you. So I'll be sharing the schedule in a while. Please go to your Discord server, do your discussion on your World MCQ, and thank you so much.
Thank you, doctor.
Doctor.
Thank you.
Thank you, doctor.